Janet Mageta, 32, calmly walked to the podium, rested her hands on the two sides of the lectern, and momentarily sank into thoughts. After a few moments, she lifted her head, and her gaze swept across the packed room, a motley crew of journalists, health workers, and government officials. It was a Thursday afternoon in Nairobi's Westlands, and the hotel conference room buzzed with anticipation. With a gentle adjustment of her glasses, Janet greeted her audience. Her voice was clear and steady, yet it carried a hint of vulnerability. She began to tell her story, a tale of heartbreak and resilience that would silence the room. She spoke of how she had contracted HIV, TB, and meningitis, a devastating trifecta that shattered her marriage and nearly drove her to despair. She described the stigma and discrimination she faced from her own relatives and her ex-husband. Join me, Steve Mokaya, as we delve into the heart of Kenya's battle against tuberculosis, a tale of resilience, triumph amidst hardship, and a nation's unwavering hope for a healthier tomorrow. Welcome.
I've been HIV positive for the last 11 years. My journey with TB started with stigma and discrimination amongst my relatives and my ex-husband. I was going through a lot. I was in an abusive marriage. At some point, I lost my self-esteem, and all I saw is that I decided I want to die.
One day, Janet said she got so ill that she was taken to Kenyatta National Hospital for treatment. There, she was diagnosed with meningitis and TB. The doctors would later call her parents to take care of her in the hospital, but when they arrived, they gave her the shock of her life, from which she had not fully recovered.
I found myself at Kenyatta. I was diagnosed with meningitis. As I was going through my meningitis treatment, I was also diagnosed with TB. When my relatives were called at the hospital, they came, they were told about my situation, but now this is where I got the shock of my life. This finished me when they told me, even they told the doctor, that it's okay, we have seen her, but all we can say is that if she dies, we won't lack a place to bury her. And that is how they went, never to return back. So I was abandoned at Kenyatta National Hospital.
The disease took a toll on her and she became blind. Her condition worsened and she lost her mind and became violent. To contain her, the doctors had to tie her to her hospital bed. But then, a glimmer of light appeared. The AIDS Healthcare Foundation paid her hospital bill and took her to a private hospital.
One day at my bedside, AIDS Healthcare Foundation were walking around. They came at my bedside, we interacted, and after that they decided to pay the bills and then take me to another hospital to receive better treatment.
There, under their care, Miss Mageta began to emerge from the shadows. Her sight returned, her mind cleared, and her strength returned. She rose from her bed, reborn, a testament to the power of hope and resilience. Now, Miss Mageta stands as a beacon of light, guiding others through the darkness of the disease. She is a TB and HIV educator, spreading knowledge and hope to those who need it most. Meanwhile, Walter Akura, another TB survivor turned advocate, narrated how TB hit him hard, robbed him of his job, and condemned him to a life of fear and loneliness. Akura was a man on a mission. Like many Kenyans, he had dreams of a better life, and he saw Nairobi as the gateway to his future. In 2014, he left his home and moved to the city, where he was hosted by friends in Kibra, one of Nairobi's largest informal settlements. Walter quickly found a job as a cleaner and he began to build a new life for himself. But then, fate intervened. Walter contracted tuberculosis, but without knowledge.
I became ill. So when I became ill, I could no longer go to work because the work I used to do, you used a mop to wash. So I used to feel like my chest is paining, I can't breathe well, my legs are weak. So at that time, I stopped going to work. Then I was bedridden.
Soon, the neighbors started asking his two friends come hosts about his whereabouts. One of the two neighbors said that Walter could have been bewitched, and she offered to take him to a herbalist. Meanwhile, the other woman suggested that he goes to hospital for a TB test. He elected to go to see a herbalist. And therefore he went to the herbalist and got treatment, but his condition worsened. He could not even sleep comfortably on the bed and started sleeping in a chair, head on the table. With the passing days, the woman who had suggested he goes for TB treatment noticed his worsening condition and took him to hospital by force.
Niliwaambia mwili yangu imekataa kitanda. What I want, nisaidie kiti, then I'll be sleeping while my head is on the table. I can't breathe anymore. So this mama noticed that, took me to the facility by force. The test came after 2 weeks, and I lost contact with them. Why? Because when I went for the registration, the one who took me there advised me, I know you fear your name. Go with the ID of your friend. And that's exactly what I did. Even now, ukienda kwa hiyo hospitali, the name that appears there is not mine. And when I started treatment, after the results came, they looked for me.
Fortunately, he was treated and recovered and has since been a TB educator, working with the medical facility where he was treated. However, the NGOs who are present at the conference lamented that the government of Kenya has for the last couple of months neglected the TB patients by failing to procure TB testing kits and TB drugs, thereby putting the lives of the patients at risk. Evelyn Kibuchi, the Chief National Coordinator at Stop TB Partnership Kenya, said Kenya has recently been faced with stockouts of crucial commodities of TB, including the Gene Experts cartridges, whose shortage, she said, has been there for a year.
We have recently been faced with stockouts of quite crucial commodities for TB, beginning with the Gene Expert cartridges, which the shortages had been there for about a year now, and now we are relying on the old microscopy, which is not sensitive enough and it cannot detect drug-resistant TB. The cartridge is a commodity that is used to test for TB. The samples are put on a cartridge, which is then put in a Gene Expert machine, and that is what is used to test whether somebody has TB or not. And that cartridge is also able to detect if there is drug resistance. That is a Gene Expert cartridges, but the drugs are what you're given once you have been confirmed that you have the TB disease.
Besides the TB testing kits shortage, Kibuchi said there has also been a long-time shortage of TB drugs which has been there for about 6 months. However, in an interview Wednesday, November 8th, 2023, she said the drugs had been procured and distribution began.
We also have had a long-time shortage of TB drugs, which has been there for about 6 months or so, but we are glad now from yesterday the drugs have been procured and distribution has begun. The first batch of about 27,000 packs were delivered and are being distributed, awaiting the next batch, which may arrive, or we've been promised is going to arrive on the 15th of November. That stock can take us up to March, after which we expect to resume the regular supply of TB drugs, which comes with a buffer stock of about 9 months.
Nonetheless, Kibuchi said the shortage of the drugs for the past 6 months was akin to creating a disaster of national magnitude.
Having a stock out of TB drugs, it's almost creating a disaster. So what has been happening is that patients have been forced to share patient packs. In other facilities, they are given for a shorter period. That means they are asked to come after just a few days to come and check if the drugs are there. And the impact of this is, one, patients are likely to fail to adhere to treatment from conditions not of their own making but forced by circumstances. We're also likely to see a rise in drug-resistant tuberculosis when the patients are not able to get drugs consistently. And finally, we are likely to see a rise in TB-related mortalities. And of course, we are going to lose the gains that we had made in TB as a country, where we had made progress. We had reduced significantly TB-related deaths and also decreased new infections. We might see ourselves now going back in terms of retrogressing in TB response.
Kibushi's sentiments were echoed by Dr. Lorraine Nyaboga, a TB specialist at the Center for Health Solutions Kenya, who painted a sobering picture of TB in the country.
Kenya is among the 30 high-burden countries for TB globally. These high-burden countries are the countries that are responsible for 80% of the global burden for TB. That's number one. Number two, TB is one of the leading causes of death. Globally, it's actually the first or the leading cause of death globally from a single agent, and it ranks higher than even HIV. And prior to COVID, it actually was the first ranking disease to cause death. For Kenya, TB is the fourth leading cause of death, and unfortunately we keep having people succumb to TB, a disease that is one, preventable, curable, and actually treatable. We actually lose, according to the WHO estimates, up to 32,000 Kenyans who die from TB every single year. This is much more than we lost over the COVID season for the 2 years that COVID was in play.
Among other factors contributing to a surge of increase in new TB cases, she said, stigma of the disease and the myth that TB means one is HIV positive rank highest.
Unfortunately, in the early 80s, when HIV became very prevalent, we started seeing an increase in the TB cases. And people started associating TB with HIV, assuming that every person with TB actually had HIV, but that is not the case. We conducted a prevalence survey in this country in 2016 to establish the burden of TB in this country. And what we saw, 83% of patients who were diagnosed with tuberculosis actually did not have HIV. Additionally, from our routine data on an annual basis from the Ministry of Health, we find that on the most part, patients with TB do not have HIV. And so we have to work together to ensure that we debunk this myth that TB means or equals HIV.
She said that most TB patients are discriminated against at their workplaces, and some are denied job opportunities that they qualify for because they have TB. She said that all Kenyans should go for a TB test to know their status and start treatment as soon as possible. Despite the challenges facing Kenya's fight against TB, Kirote Muirigi, the national coordinator of the National TB Program in Kenya, said the government is still on course in pursuit of the disease through multiple modus operandi, including active case finding.
One thing the government has put in place is to ensure that we find all these people missing with people with TB. We did a TB prevalence survey in 2016 that showed that out of our systems, we were missing nearly 40% of our cases that go undetected and untreated. So because of this, the government has put on some measures to be able to find these people missing with TB, or those that we term missing with TB, because they are in the system and are undetected and are untreated. So what we've been doing is, one, we've been doing a lot of actively finding these cases, or what we call ACF, active case finding, whereby within the facilities, we ensure that everyone who present within the facility, they are screened for TB. So we put them on treatment early enough and ensure that they have good outcomes, and we treat them effectively.
In addition, she said the government does routine testing of truck drivers along Kenya's transport corridors to find truckers with the disease who might be oblivious.
We have other innovations that we are doing, especially across the transport corridor, testing the truckers and truck drivers along the transport corridor to be able to find those people who are with TB and don't recognize their symptoms.
Moreover, the government, she said, has put up TB manyatas in the arid and semi-arid counties to test, confine, and treat TB patients.
People who are vulnerable, especially during displacement, overcrowding, end up suffering more. What the government has been doing is that to ensure, especially those counties that have TB manyatas, especially in the northern and Asal counties, we ensure that we bring people who've been diagnosed with TB together to be able to monitor them for treatment during the period that they're on treatment, so that they then stop migrating, because the problem is usually they're migrating because of pastures and animals. So what we do within the TB manyatas is that we ensure once they are here within the TB manyatas, we take care of them during that period.
Many thanks for your company. My name is Steve Mokaya.